Good morning, everyone. Good morning. Welcome to this session, the Ypsomed session on automated insulin delivery with mylife CamAPS FX to manage type 1 in childhood and adolescence. Hopefully some practical insights for you. Thank you so much for finding this room so early in the morning. It's really nice to see all of you. I'm Julia Ware, and this is my colleague Martin Tauschmann. I'm a clinical research associate and a pediatrician, and I work with the Artificial Pancreas Group and Roman Hovorka at the University of Cambridge doing closed-loop research. And Martin works at the Medical University of Vienna and is a pediatrician there, and also has a special interest in technology and has also previously worked with the Artificial Pancreas Group at the University of Cambridge. So hopefully today we can give you an overview about hybrid closed loop and the challenges in childhood and adolescence, as well as some nice clinical cases. The idea is to be fairly interactive and informal, so we'll take questions at the end of each case. Just raise your hand if you have a question and someone will come to you with a mic. And yeah, keep the questions coming, keep the discussion flowing. It'd be really great to hear from you and your thoughts on what we're presenting. So these are our disclosures. So I'll be talking a little bit about addressing the unmet needs to manage type 1 in children and adolescents first, and then we'll move on about managing some more challenging situations with the mylife CamAPS FX automated insulin delivery system. So I think we can all agree that up until now, despite all the advances in the last 100 years, there are still many unmet needs across childhood in type 1 diabetes. And you can see some data here from the SWEET registry, looking at mean HbA1cs throughout the childhood and adolescence, comparing 2008 to 10 to 2016 to 18. And while you can see that mean HbA1c has dropped over that time, mean HbA1c remains throughout childhood well over 7%. And the ISPAD goal, of course, now is 6.5% or below. So we're still sitting well above that, even with current treatments. And similarly, if you break it down by treatment type, you can see here some data from the DPV registry and the T1D exchange, looking at mean HbA1c depending on treatment type, so from injections with finger pricking over to pump and CGM, which of course until recently was sort of the gold standard treatment. And you can see that even in those using pump and CGM, HbA1c remains well above the target at 7.5% in the DPV registry and 8.2% in the T1D exchange. So with with what was previously gold standard therapy, we're really not meeting treatment targets across childhood, regardless of what treatment is being used. Additionally, different age groups through childhood have particular challenges, and we all know from our clinical practice that in particular young children can be very difficult to manage, and part of the reason for that is that they have such high variability in insulin needs. And here you can see some data looking at variability of insulin requirements expressed as the coefficient of variation during closed loop use in different age groups during the day and at nighttime. And you can see that in very young children under 6, and also in school-age children 7 to 12, the variability of insulin requirements is higher than in adults and in older children. And so it's very difficult for parents and for children to continually adjust therapy to match these varying insulin requirements using traditional methods. And if they try and match it, then I think often that leads to high burden and diabetes burnout. Of course, we all know about the tricky years, adolescence. That can be a very, very challenging time to manage glucose levels. And this data just, again, looks at HbA1c throughout the childhood years across different countries. And you can see that even in countries who have really excellent glycemic control overall, like Sweden, HbA1c really consistently starts rising from about age 10 up until age 18. On top of the glycemic control, of course, is also the quality of life factor. So children and their families really feel a huge burden with type 1 diabetes. They talk about how diabetes takes over their lives. They can't think about anything else. It's a huge burden of care for parents. People aren't sleeping, especially parents of very young children, worrying about school. There's a financial impact. People worry about risk of complications. So the quality of life impact is huge. Now, automated insulin delivery, of course, has been presented as a solution to address a lot of these issues. And increasingly, hybrid closed-loop insulin therapy is being used in clinical practice over and above the previous gold standard sensor-augmented insulin pump therapy. And today, in particular, we'll be presenting some clinical cases about mylife CamAPS FX. So CamAPS FX is the Cambridge Model Predictive Control algorithm, which resides as an app on an unlocked, currently Android phone. And it acts as a CGM receiver, so you get all your alerts and alarms as you normally would using your CGM. And you can also bolus from the app on the phone. The data automatically gets uploaded to Gluco. And in terms of remote monitoring, there's also a companion feature, which is essentially a mirror version of the app that carers can have on their own phones, where they can see data in real time. And you can also get real-time SMS alerts. And the app communicates with the mylife Ipso pump, and then people with type 1 have a choice of 2 sensors, so they can either choose Dexcom G6 at the moment or the Freestyle Libre 3. So it's up to the person with diabetes which sensor they would like to use. The app is also personalizable, so there's a few features where people with type 1 can make some treatment decisions. So they can set a personal glucose target that's adjustable in 30-minute segments from 4.4 to 11 over the 24-hour period. There's also a boost function, which is unique to the algorithm, which is a user-initiated intensification of the algorithm, where insulin delivery is increased by around 35%, and boost automatically stops when glucose is back in target. Even you don't need to switch it off. And there's also the ease-off feature, which is fairly similar to exercise features across other closed-loop systems, where the algorithm becomes more relaxed and the glucose target is temporarily increased and insulin delivery decreases. And all these things can be activated directly from the app user interface. As I said already, the remote monitoring capabilities include the CamAPS Companion now, which is a mirror app that up to 10 companions of the person with type 1 diabetes can download onto their phones. And as you can see here, essentially they really see exactly the same app that the child with diabetes would be using. They can see all the data in real time, except that all the functionalities are disabled, of course, so you can't bolus from the companion or anything like that. The CamAPS FX algorithm has really been extensively investigated with many randomized controlled trials, and this is just a sort of summary slide to show you the randomized controlled trials that have happened in Cambridge, and particularly in children. There have been many studies, so in very young children, we've done 3 randomized controlled trials ranging from 3 weeks to 4 months, and then in children and adolescents, we've done randomized trials ranging from 12 weeks up to 2 years, and actually now 4 years, which data will be published soon, and also randomized controlled trials in adults, older adults, and in pregnancy. And I'll just give you a really quick sort of highlights overview of some of the pediatric studies that we've done in Cambridge with CamAPS FX. So first of all, hybrid closed loop in very young children. So this was a multinational, multi-center study in very young children aged 1 to 7, 74 children we recruited. They used closed loop over 16 weeks. It was a crossover design, so 16 weeks closed loop, 16 weeks pump and sensor. And baseline HbA1c was 57. And with hybrid closed loop, the time in range increased by 9 percentage points in these very young children, and there was a significant reduction in HbA1c of 0.4%. No difference in time in hypoglycemia, and also a significant reduction in mean glucose. And here you can see the 24-hour glucose profile. And in red, you can see closed loop, and in gray, sensor-augmented pump. And you can see that throughout the 24-hour period, mean glucose is lower with hybrid closed loop compared to sensor and pump. And the effect is particularly marked overnight. Next, we did a study in closed loop in children and adolescents. This was a 6-month randomized controlled trial where we compared closed loop with pump plus minus sensor. So some children with pump were using a sensor and some were not. We recruited 133 children across 12 centers in the US and the UK, aged 6 to 18. For various reasons, we ended up using 2 different hardware platforms for the same algorithm. So we ended up splitting the results into CamAPS FX, which is the current hardware, and the slightly older hardware, which was Florence M. And this was particularly children and adolescents who had suboptimal glycemic control, so baseline HbA1c was a bit higher at 8.2%. And looking at the CamAPS FX cohort, which of course mirrors the current hardware that's being used, time and range improved 15 percentage points in these children and adolescents, and there was a reduction in HbA1c of over 1 percentage point. A significant reduction in mean glucose, and again, no difference in time and hypoglycemia between the 2 treatment arms. And here you can just see, I guess, the importance of hardware usability that we really found in this study. So in the white dots are the Florence M, which is the older hardware, which had some technical issues, and there were issues around staying in closed loop, and CamAPS FX hardware, which is the sort of more current hardware where connectivity was more reliable. And you can see closed loop use versus change in HbA1c, and it shows quite nicely that with CamAPS FX and the sort of current hardware setup, closed loop use was very high consistently, and therefore also there were consistent reductions in HbA1c compared to Florence M, where the hardware was a bit more tricky, and so closed loop use was very variable, and you can see the reduction in HbA1c was also much more variable. Lastly, we did a study looking at closed loop from onset of diabetes in children and adolescents. And this was a study where we recruited 97 children across the UK, aged 10 to 16, and they were recruited within 21 days of diagnosis. And the study lasted 24 months, and we compared hybrid closed loop to just standard care. So that could be anything from MDI up to going on to closed loop, depending on what the clinical team decided. And the primary outcome of this study actually was to look at C-peptide, so looking at pancreas preservation. And what we found was that despite the fact that there was significant improvements in glycemic control in the closed loop group, there was no difference in C-peptide. So the C-peptide area under the curve was not different between the 2 groups, but you can see here quite nicely that HbA1c, whilst at the beginning they're very similar, by the end of 24 months, the 2 groups really start coming apart, and in the closed loop group, HbA1c is staying nice and stable around 50, and in the control group, HbA1c has risen to about 60 millimoles per mole. So that's a difference of around 1%, and mean glucose was also significantly lower in the closed loop group, and time and range was 14 percentage points higher. So that was a sort of whistle-stop tour through the really important studies that we've done in Cambridge in children and adolescents. But of course, as I mentioned before, the psychosocial benefits are so important, and within these studies, there was also significant work done around looking at quality of life benefits of hybrid closed loop. And a group based in Edinburgh did structured interviews with a lot of the families taking part in the studies. And what they found in the very young children was that using hybrid closed loop led to better well-being and less hypoglycemia fear in caregivers. The parents worried less, and they were able to leave the children with other caregivers when they were using hybrid closed loop. They felt that life in general was much more normal. And parents really liked being able to bolus from the phone because they didn't have to go to the young child and take off the pump and interrupt play, interrupt sleep, etc. In the adolescents, they particularly valued being able to do with everything from the smartphone, which they found much more discreet, not having to show everyone that you've got diabetes. And they reported that they were actually able to review and check the data much more frequently because it was possible to do so on the phone. Some of them actually said they sort of forgot they had diabetes, and they would maybe do a bit less about their diabetes, which I think you could arguably say is a good thing. Closed loop really enabled them to kind of decide how much they wanted to be involved with their diabetes, whether they wanted to look at the data a lot or not so much. So huge quality of life benefits as well on top of the glycemic benefits that we see here. And just really quickly looking at some real-world data. So this is fairly new data from CamAPS FX commercial users. And you can see the overall and then also split by age group. And you can see really that the time in range 3.9 to 10 on average across all age groups in the real world was 72%. So that's fairly similar to what we've seen in the randomized controlled trials, with about 67% time in range in the under sixes, up to over 80% time in range in the older adults who tend to have very tight control. And so really this mirrors what we've seen in the randomized controlled trials, that really is translating into the real world and real world use. So that was our whistle-stop tour through the unmet needs in childhood and also some of the data from our Cambridge research. But I think, I'm sure everyone's very interested to dive into some of the clinical cases. So I'd like to introduce Martin now to start us off on the first case. And yeah, just remember, we'll take questions at the end of each case. Thank you.
Thank you, Julia. Good morning, everybody. So we have put together a series of, we hope, very interesting cases for you. Some of them are not straightforward, and for some of the cases, there's no one-fits-all solution or approach. So there should be a discussion at the end of each of the cases. And yeah, these are all cases where we were using the CamAPS FX system and its particular features, and we just wanted to illustrate how it worked in these kids with diabetes. So the first one is a challenging one. It's an adolescent struggling to meet glycemic targets. So he's 15 years now. He has had diabetes for quite a long time already. He also has other diagnoses, ADHD and hyperlipidemia, for example. And there is a complex family history. His parents were originally from Afghanistan. He has a sister with type 1 as well. And it's a bit tricky in terms of psychosocial circumstances. So the family doesn't live together. The boy is actually now in foster care. He lives in shared accommodation, looked after by a social worker. So a very tricky situation. And his diabetes management has deteriorated over the time. So that's quite an impressive peak in terms of A1C. You can see it up here. Yeah, initially everything was running more smoothly, and okay, then adolescence kicked in and other problems as well. So back then in 2014, he was put on conventional therapy. They just arrived from Afghanistan, family, and there was a language barrier. The educational level was not that high. So anyway, the decision was made. Then he was actually put on a pump and capillary measurements, and then we thought to introduce a sensor as well. It was a pretty nice idea. For any reason, he didn't get on very well with the Medtronic sensors, so he decided to use Freestyle Libre sensors. And then at some point we said, okay, we should try maybe an automated insulin delivery system. Back then, the only system available was the 670G, and he used it for a month. And then again, he struggled with the sensors and wouldn't use the sensor and wanted to use his Freestyle Libre again. He had also an episode of severe hypoglycemia and several inpatient admissions even to optimize his therapy. So we were really struggling, and he was struggling with his glucose control. So, and then in June this year, there was an outpatient visit. His A1C was very high, 11.2%. And this is the pump download. It's quite small, but you can see it is hardly bolusing. The levels entered are actually the scanned levels from the Libre sensor. So he's not his insulin needs were around 60 units a day, mainly living on his basal rate. So very high readings all the time. And this is the sensor glucose download. He was actually scanning quite frequently. Not quite sure if he was scanning towards the end of the, towards the outpatient visit. So he has 10 scans a day, so probably, yeah. Anyway, so the coverage in terms of sensor use was okay-ish, but his time in target was just below 30% and with very high readings, but also low readings, so a huge glucose variability. And yeah, and then we sit together and decided with him that probably it would be a good idea to start an automated insulin delivery system again, using a different sensor, using a different pump, and starting the whole thing in an inpatient setting. This is also a link to the Austrian system. It works because we have more diabetes educator, etc., and more resources for inpatient care than for outpatient care. But in this particular situation, it was actually a great idea anyway. Yeah. So, and in Austria, we're also lucky that we have reimbursement for all the technologies, and even switching technologies in children and with diabetes is actually easier than in adults. So if you start them on an automated insulin delivery system, and then a year later you want to change again, so very often, or in almost all of the cases, we manage to get it approved, the change. So we're in a lucky situation. Anyway, so there was a hospital admission, 7 days in total. Initially, we tried to optimize his therapy. He was using his current technology with Medtronic pump and LibreSense, and then there was a switch to the CamAPS system and Ypsomed pump. And these are the results of the 3 days in hospital setting. So we didn't achieve the 70%, but almost 69% in target. So he was giving more boluses because he was looked after by the nurses on the ward, etc. So yeah, this is compared to a time in range of 29%. This was actually quite good. But of course, we knew that this is inpatient, so we were really much looking forward to the next outpatient visit. And this is just a day on the ward. 86% in target, so the system worked if he would actually give his boluses on a regular basis. So that was good confirmation, and that's the follow-up 1 month or 2 months later. Now the time in range is not 70%, but 56%. He has some lows as well. The CV is actually quite high. Yeah, his total insulin dose actually has dropped again, from around 80 or 100 units on the ward down to only just under 60 units. His A1C has improved. Okay. Again, he's not bolusing a lot, so he's using the hybrid closed-loop system in a more or less fully closed-loop mode. Yeah. This is what a lot of our adolescents people do. And this is the chart just looking over 14 days, and you can see a lot of variability, lows and highs. Some days are actually better. Although he's only giving 1 bolus, actually the system is coping very well. Yeah. If it's used on this particular day, it's used for 89% of the time, so that's good. If the system is used by the young man, then it's actually working. And then there are other days where he is actually not using the system a lot. In the afternoon, you can see he was on. This is the system is not working. It's in open mode, or maybe it was given a correction here, going down, and then he put on the auto mode. But then, okay, the auto mode didn't deliver any insulin, but I think due to the correction here, he went down to hypoglycemia. Then again, no bolus. The system was trying hard to give insulin. Eventually, it came down, and then he just left the phone somewhere, and there was a disconnection. So there was no closed loop, not auto mode being functional over this period of time. So again, low, and then high up again. He turned it on again, and coming down again. So this is a day, a typical day of the young man, and I think this might be similar to adolescent in your centers as well. But the key message here is that the use of the CamAPS system in Ypsomed pump is actually safe in this particular patient. It is efficient. It is delivering better care than he had on previous systems, and he gets, even if he's not bolusing, he gets better results. This is also in line with recent publication by Roman's group, using having a fully closed loop approach in adults. So we thought it was actually a good idea. Of course, we will see how the story will go on. It's only a 3-month follow-up now, We hope that he will continue to use the pump, that he will not leave his phone somewhere, so that the closed loop could do its work. Yes. So that's the first case. Are there any questions or do you have similar experiences at your centers, particularly those using the CamAPS system already? So, yeah, microphone.
Oh, yes, someone just coming with a microphone for you.
Thank you so much for this case study. I was wondering if there was an effect on the body weight of this guy as well, because he started with a huge number of units of insulin, which must have had its effect. And when he diminishes his total daily insulin, there might be an effect on his body weight. Is something known about that?
Initially he was gaining weight again after being put on the system, because when he was discharged, he was on roughly 80 to 100 units, yeah, and prior to that he was only in 60 units. And then in the follow-up, I think it was going down again a bit, but it's just 3 months follow-up now. But this is an interesting question, yeah, you're right.
Thank you so much.
Thanks, Martin. I think this is a very common case we see in UK as well anyway, these teenagers. And you said that in Austria, you admitted this patient in the ward
Yes.
to provide intense education.
Yes.
And do you really feel that it has made a significant impact in the 3 months' time? And the reason I'm asking is we do admit the patient electively for a week or 5 days, just to make sure that we provide that re-education. Mm-hmm. But is it really making the impact? And also referring to your case as well, if you could expand, please. Thanks.
In this particular case, I think the difference was really the automated insulin delivery system, because we had admitted this guy several times prior to that on inpatient setting. So it was always the same. Inpatient was fine, he was getting education, but at some point he wasn't taking on any information, he was just refusing to participate in the training sessions and just didn't want to care about his diabetes at all. So it was tricky, and now I think, of course, we did again educational sessions, particularly he needed to be trained up on the system, and I think that worked relatively well. But then the follow-up, I think it's really the difference is the automated system now used with this patient or young guy with diabetes. Any other questions?
Okay, next
So
case.
let's move on to the next case. Julia, the stage is yours again.
Okay, so now over to the other end of the pediatric age spectrum. This case is about using automated insulin delivery with diluted insulin in a newly diagnosed toddler. So this is an 18-month-old girl who presented in moderate DKA, had an HbA1c of 106 at diagnosis, and was started on Dexcom G6 within 24 hours of admission to the pediatric intensive care unit, and then was started on Ypsomed and CamAPS FX on day 3 of the admission. So basically went kind of straight from IV insulin onto closed loop, and that's generally how we do things in Cambridge with the newly diagnosed young children, because in the UK we don't tend to have lengthy inpatient stays. We try and get them out of the hospital as soon as possible, and then do most of the education on an outpatient basis. This child had a total daily dose, we estimated, of around 6 units, and weight was 12.1 kilos. And on the pump itself, we set basal bolus as 50-50 of that 6 units as a backup. Of course, that's not used when the system is in closed loop, but just in terms of the backup settings on the pump. And then we used a U10 dilution. And to do that, we physically label all of our pumps. So we put big stickers on the pump saying this pump contains diluted insulin, caution. And we have electronic systems that we use, so we can put an alert on the records to say this patient is on diluted insulin, be careful. And initially we set all the carb ratios to 1 to 5, so that's equivalent to about 1 to 50. And we set the insulin sensitivity factor to 1.2.5, which is equivalent to 1 to 25. And we set the basal rate at 1.25 units. Again, this is just backup. The closed loop system does not use the basal rates that you set when you're in closed loop, but if you're not in auto mode, that's what the pump would fall back on. And again, just dividing that by 10, equivalent to 0.125 units per hour. As I mentioned previously, with CamAPS FX, you can set a personal glucose target quite widely between 4.4 and 11, and because this was a newly diagnosed toddler and we weren't 100% sure about the total daily dose, we decided to go with a fairly high personal glucose target just at the start to try and prevent hypoglycemia, particularly because, like I said, we try and move towards discharge fairly quickly. So we don't like the patients to have big hypos before they go home. So just thinking about dilution, I know it's a sort of contentious subject. Some centers like to do it, some centers don't like to do it. We find that with a total daily dose of under 8 units, it's worth considering because the closed loop system does have just more wriggle room in terms of how it can deliver insulin when you dilute. And you don't have these long periods of no insulin delivery that you sometimes get with these very small total daily doses, especially overnight, and therefore you're suppressing ketone production. But it depends a little bit on where you work. So some centers, the pharmacies will dilute the insulin. In Cambridge, the parents have to dilute the insulin themselves with the Novo Nordisk diluent. So again, as a team, we just sit down and we look at the family and we think, will they be able to cope? Can they manage to dilute at home? So it's really a kind of case-by-case decision as to what we think will work for the family and whether they're happy to go ahead and do that. That's why we tend to go with U10 because maths-wise, it's sort of the most straightforward. But the ISPAD guidelines do say that young children might benefit from diluted insulin to allow for more precise dosing, and that you should dilute with a diluent obtained from the manufacturer, and we tend to use the Novo Nordisk one, and they say you can dilute to U10 or U50, and then store for up to 1 month. And like I say, we tend to go with U10 just for ease of calculations. So like I say, you just need to think about who will dilute if you're going to dilute, what's your policy, do you have a standard operating procedure, making sure everything's labeled for safety purposes, and you have put a notification on every possible system so that when they present to hospital, everybody knows that they are on diluted insulin and that they're not getting 40 units a day, but in fact it's just 4 units. And you of course need to supply families with diluent and syringes. We obtain those via our hospital pharmacy. Again, it depends on the country that you're working in, and Novo Nordisk supply their diluent free of charge. So this was day 1 of this little girl using closed loop, and you can see here that levels are obviously still fairly high, and we're just sort of getting to grips with what's happening. This is with the target set at 10. And you can see really fairly quickly that she's not getting enough insulin, and it looks like she's getting 67 units, but it's really just 6.7 units. And overnight, she's running a little bit high, and then after eating, she's really shooting up. So the first thing that we decided to do here was strengthen the carb ratio. So we went to 1 to 40, and we also reduced the glucose target down to 9 after this day because it was very clear that she needed more insulin. So on the app itself, you can set the personal glucose target. The default is 5.8, but you can adjust it between 4.4 and 11. We, like I say, often in the younger children do start higher when we initiate the algorithm. I think if you're in an inpatient setting, you could probably start lower. But because we tend to discharge our patients fairly quickly, we start a little bit higher in the young ones. Some people, more adults, really sometimes lower their targets if the glucose variability is low, especially overnight. And of course, in pregnancy, the lower targets are used. In pediatrics, I would say it's more that we sometimes raise the target if there's frequent hypos, for example, or there's risks of lows. So often if people go on like a skiing holiday, for example, we might say, oh, you might want to raise your target a little bit for the duration of the skiing holiday, for example, to avoid hypos. And what we've really found, and what also another study that we've done showed, is that you need to raise or lower the target by at least 1 millimole to really see a clinical effect. So raising it by sort of 0.5 is probably, you're not going to see any difference. You need to go in kind of 1 millimole increments. So now looking at her data on day 3, you can see already that whilst obviously she's still running on the higher side, the profile is now much flatter. So we're not seeing these huge peaks and troughs anymore. So what we did there was we decided to strengthen the carb ratios again, because you can see that after the boluses, the system is often still giving quite a lot of insulin behind, suggesting that really we could give more with meals. We didn't want to do everything at once, so we kept the target high at 9 still. And now looking at day 5, you can see that we're much more in target already. So the system is not giving so much insulin behind the boluses anymore. You can see that quite often insulin delivery sort of peters out after a bolus, which is kind of what you want to see. And you can see also that whilst at the start of the night she's high, she then comes down quite nicely. So at this stage, we reduced the glucose target to 8 because things were looking quite stable. And that worked very well. So this was day 18. And you can see that it's not an ideal day because there's some times where she's in open loop. You can see by the flat profile. But overall, she's much more in target. Of course, you all know with a toddler, not every day looks like this. But overall, things are much more in target. And at the end of the first 4 weeks, she had 73% time in range and 4% time below range on around just under 5 units a day with the U10. And that is the end of that case with diluted insulin. And what we tend to do is we tend to try and go back up to U100 sort of as soon as it's feasible. So we look at total daily dose and weight and things, and as soon as they sort of hit the point where we think we can not go with diluted insulin, we try and switch them back. Any questions?
Thank you so much for presenting us this toddler. I had a question about the speed in which you want to decrease the HbA1c, because the toddler started with a HbA1c from
106, yeah, at diagnosis, yeah. Mm-hmm.
And you are setting the personal target, glucose target, quite swift to 8. While I think the mean glucose must have been about 12, 13 to achieve HbA1c from 100 and so much. Do you have a certain guideline for the speed of decreasing the HbA1c in a child which must have had diabetes quite a long time before being diagnosed? Do you have any guideline for this?
So we don't have any official guideline that we use in Cambridge clinically, particularly. Like I say, in the younger ones or when they present to PICU and DKA like that, we do tend to go fairly slow. I know you say we already went down to 8, but we kept the target at 8. So at 4 weeks, we were still at a target of 8. So we hadn't gone any lower than that. That's just like you say, to try and not decrease things too fast. But we don't have a sort of hard and fast rules. Yeah, it just depends a little bit on the individual patient.
Hi, Julia. That's great. I think you demonstrated a problem that we have, that the families tend to switch off the system when they're really approaching baseline. They panic and they interfere with the system. I think if you go back onto your last slide, you'll see where they went into manual, it was flat. It was probably that they were beginning to head under or towards baseline. Have you got any tips other than leave it alone? Because that is a really recurring problem for some families, trusting the system. Not your system.
No, I think in general.
Systems.
Absolutely.
Yeah.
No,
I don't want Roman to get upset.
No, thanks, Vienna. I think, there's always those families who really struggle to trust. I don't know why. I mean, we're just speculating. I don't know why they were in open loop there. Could also be that, I don't know, they left the phone somewhere. It was more than 6 meters away. I mean, who knows? But yes, you're absolutely right. And I think when you look at the qualitative research that's been done in the very young children, of course, what you see is that families report that one of the things they struggle with the most is to trust the system. Mostly people do come around to it and they look at the data and they start seeing that actually by the time they do something, closed loop has already stopped giving insulin. So the system is quicker to react than you are. And eventually most families, I think, do do catch on to that, and they see that actually if they interfere, it tends to make things worse, not better. I think there are always going to be families where no matter what you say and what you do, they just feel the need to fiddle and meddle. And I unfortunately don't have a sort of answer to what to do there. I definitely have a couple of families who I work with where I feel like no matter what I say, they just can't help themselves. Yeah. Mostly, though, I think with time, people do learn to trust. I actually find from diagnosis it's often easier because they're not so used to having to do loads. It's often parents who are used to just pump and sensor or MDI who struggle more because they're, especially of the young children, they're really used to being on the case all the time, and they have a hard time stepping back more so than the newly diagnosed ones, I think.
Hi.
Yes.
I think the easier it is for a family. We found it with CGM, got them on the first week, they accepted it very well, wait a few months, and they've got their own ways of coping, I think. I think that's, so I think this, I mean, I presume we're still, for most of us, we're not starting these systems quite at diagnosis yet. And I think that's a really important point, that it's going to be much easier for the families if this is the way that they're presented.
Yeah, I think the only other thing I suppose to think about with diluted insulin is that quite often you then run into issues around if they have ketones, they often have to present to hospital straight away because you can't do any pen injections because the doses are all too big. So that's just something to bear in mind.
Sorry, just Julia, you mentioned about changeover to normal U100 insulin. What point would you consider, because anything above 5, I mean, you said that close to 5, you wanted to dilute it, but you didn't give us any figure at what point you would change over to U100. This is to avoid errors. The reason is we have put 3 kids in our unit on a tethered insulin pump, tandem T-Slim, and they were 15 to 18 and 20 months, and we didn't dilute or anything. Their insulin requirement 7 to 8 units, 3 of them actually. So it is a poster here. So we didn't have any problems, actually. And most of the time, the pump was suspending anyway, so.
And sometimes people don't. I mean, there are also centers that use CamAPS FX, and they use it with 6 units or 7 units, and they don't dilute, and it goes fine. I certainly know, for example, from colleagues in Hanover, that they have kids on those kinds of TDDs, and they don't dilute, and it works okay. I think it's really patient-dependent. We've had good experience with diluting, and I think under 8 units, we would always consider diluting, but sometimes we don't dilute straight away, and we just kind of see how things go with U100, and if it becomes clear that actually the closed loop's suspending all the time and we're seeing lots of ketones, then sometimes we switch a little bit later. I think with her, we were fairly certain that her TDD would actually be below 5 units, which it kind of turned out to be. So I think everyone always wants sort of exact numbers. I think, you're from yourself in clinical practice, things are always a bit more gray than that, and it sort of depends a bit on the family, it depends a bit on the circumstance. I think in terms of going back up to U100, I think once they're over 10 units TDD, I think we tend to sort of really start thinking about it, partially also because then you're on 100 units of the dilute, and then the Ipso only holds 170, so you're looking at quite a lot of cartridge changes and having to dilute more and things, and it becomes increasingly more effort for the family. So I think always balancing that and then kind of switching to U100 as soon as is practicable is the way forward, really. Yes?
Thank you, Julia, for this very nice presentation. What is your experience with the remission phase? Yeah, because the total dose will be completely different when you start quite at the beginning, and maybe it will be the half 3 weeks later. What's your experience?
Yeah, so in the really young kids, I don't know about your clinical experience. We don't tend to find there's a huge remission so much. They don't tend to drop their TDDs, not like the older kids who have that really big honeymoon. I think we don't see that so much in the toddlers. Yeah, I think you said the same. So I think, and they're the ones that we tend to go from diagnosis. With the older kids, in terms of funding so far, we haven't been able to start from diagnosis in clinical practice. So I can't really comment. I think Martin is presenting a case about exactly that actually in a minute, looking at honeymoon in a school-aged child. So yeah, watch this space. I think we better move on now, but obviously we can always still chat about more questions later.
Okay, now it's me again. It's a school-aged child using the automated system right from diagnosis. So this is the presentation, typical presentation, polyuria, polydipsia, and weight loss, BG almost 700 milligrams per deciliter, but no TKA actually. It's usually Friday evening, isn't it? No diabetologists around. And so they started with an MDI therapy, probably. If there would have been a diabetologist on the ward, we would have started with a pump right away in our setting. Bear in mind, Austria, again, we get reimbursement for insulin pumps and CGM and AID systems right away, no problem. Okay. So this is, MDI and capillary measurements. Then on Monday, the team was around and we presented all available pumps, and there was a discussion of pros and cons, as you know. Then the family decision was to start insulin pump therapy. So we have a pump on the ward. Usually we start, and we do all the requests for approval. We have starter kits as well. For this particular family, we started with any insulin pump we just had there. And then the decision was made to also start a sensor. So we added Dexcom G6 because we thought the family might be keen to use Ypsopump and CamAPS, and then the decision was made for Ypsopump and CamAPS, and we got all the approvals and we put them on their pump using one of the starter kits we have on our ward. And then after 2 days we started the auto mode. So this is 14 days admission to hospital. That's what we usually do at Austria. In Austria, we've spent quite a lot of time for training, for initial training in an inpatient setting. Yeah? I think in Germany that's a similar system. Elsewhere it's different in the UK, as Julia already mentioned. And then he was discharged with a running AID system. So this was the open mode phase where we still try to establish the carb ratios and actually also basal rates for this particular boy. And then we started the auto mode. So the advantage is we had already established carbohydrate ratios. We had a good estimation of total daily dose from the preceding week using pump and sensor. And we actually, in this particular case, we decided let's go for the predefined target, which is 104 milligrams per deciliter on the Ypsopump. And it actually went quite well to start with. And then we had a follow-up visit. This was roughly 1 month later in our outpatient clinic. The A1C had dropped already, but then we were seeing actually the total daily dose was much lower initially. He was discharged with 15 units. Now it's only 8 units, so there is a remission phase. And then we were seeing quite a lot of hypos, so above the recommended thresholds. The time in range was great, but also we were worried, and the family was also worried about hypoglycemia. So then we also actually looked at the download and see that ease off was actually not used very frequently. So we decided to, this is the overall picture we got. So still a lot of variability and a lot of lows, particularly after meals. You can see it here. So maybe overnight, the closed loop system was actually, it was on the lower side here, although hardly any insulin was delivered here. And then after meals in the afternoon, there was a drop again. So we decided we should make some adjustments to the settings. Yeah. So that's why we went for less aggressive carb ratios throughout the day. And we increased the target. I just learned that probably we should have gone up to 120, not only just 10 units, which is great. It's a learning process. And we taught the family that they should actually use ease-off feature more frequently. And this is what we were seeing then at the next follow-up visit. So the hypoglycemia levels, they are not, well, it's a reduction in hypoglycemia, and insulin requirements are still low, fewer hypos and less variability, which is actually what we're aiming for. So the key message here is that CamAPS from onset is feasible, safe, and it's effective. The way you start the closed loop system might vary from your individual settings, and also if you get approvals for these systems in certain ages, and if you have the systems available right away or not. And CamAPS, although the way we approached it might not be the best way, it is actually feasible to deal with the honeymoon phase. And of course, you should maybe you have to make some adjustments. And in future, we will actually probably start with higher targets, even if we had it established settings at onset when we started the auto mode. So yeah, that's a learning curve as we go along using the systems. So any comments or any questions from your side? Roman. Oh.
Yes, I have a question. Just during the remission step, we have to change the total daily doses too, or not?
We don't change the total data, but Roman could comment on this, perhaps.
Thank you. Can you hear me?
Not that good.
It's not on the mic.
It's not on the mic.
No, you don't need to press anything.
I mean, we can still hear you.
Hello? No? No. Okay. So we've done study with we've done study with newly diagnosed teenagers, and again, the closed loop will ramp up the insulin delivery. You don't need to change it. What you need to change is the basal pre-programmed basal, because it's the backup when people are not on the closed loop. So that's what needs to be learned, I think, especially during the honeymoon phase. So, but the system will do it behind you. What I'd like to mention is that what I've seen, or we've seen in the studies, that people are saying there's lots of hypoglycemia in children as well, post-diagnosis. And I just want to say is, quite often, if you measure glucose in healthy children overnight, they will be pretty low. They will be below 3.9. And I think these children are in honeymoon phase, and I think the pancreas will still be secreting insulin. So what you're seeing is actually normal. It is not unusual. And you could see in this case, there was actually hardly any insulin given one of the night, which Martin was showing. And parents are still worried about 3.9. So I just want to say is one needs to take some of the hypoglycemia or near hypoglycemia is physiological in these children. So I would not say be too much worried about it. The other thing which I wanted to mention about the body weight and the higher total dose, if somebody present with high A1C, they usually have a resistance to insulin, so they will need more insulin for a few days or few weeks. And once you get through that, you will see the drop of insulin needs, like in that case which was shown before, where you drop from 100 to 50 units as well. So that's part of the story. You need to intensify when you go down. And in terms of body weight, we've seen in lots of studies is that closed-loop system doesn't increase body weight, and it doesn't increase insulin dose. So this is sort of general message on that, sort of not just our system.
Just to say that clinically, some centers do, for the honeymoon phase, have a lower threshold for hypos. So some centers will say 3.5 is a hypo and below, rather than 3.9, for example, to address exactly that. I think we had better move on because I think it'd be nice to at least quickly cover exercise, if you agree, Martin.
Okay.
We have 5 minutes, oh, yep, sorry, quick question.
My name is Przemka Jaroszowot and I'm from Poland, and we are really, really fan of CamAPS, and thank you, Roman, that you organized something, a beautiful device. But I would like to underline that you must be aware of sleeping on the sensor, on the Dexcom. And sometimes you have hypos the whole night, and this is that you sleep on the sensor. And you press the sensor. So you just to be underlined, be aware of such things, that there's not hypos, that is there's the not proper use of sensor. That's it.
Thank you for the compression lows, yes. This is a problem. So the next case is actually about exercise. When looking at the data from our center, I couldn't find any competitive athlete here. So this is maybe more the daily life of children using the system while they are physically active. We know different kind of exercises have different impact on glycemic excursions. This is well known and well described, and this is taken from Mike Riddell's famous Lancet paper. And with the CamAPS system, we have a special feature, the ease-off function. You could use it to make the system more gentle, and the personal glucose target is automatically raised and less insulin is delivered. You should start it ideally 60 to 90 minutes prior to the activity. Of course, that's always easy in a setting with a toddler, for example. And you can extend it up to 6 hours post-activity to avoid even delayed hypoglycemia, and use overnight if they have been very active during the day is also recommended. These are just some general advice. And well, we all know the less active insulin there is, the easier is it to manage exercise. But we all know that the approach to exercise is different and has a high inter-individual and intra-individual variation in terms of response to exercise. So all these decisions with exercise, they are very individual, actually. So the ease-off feature, just to demonstrate how it works, you could, from the home screen, you could actually just press the button ease off, and then you could put a duration for how long you want the system to be in ease-off mode. And then actually you can start the ease-off right away, or you can even schedule it for a later start. For example, if you want to go for a run first thing in the morning, you get up at 7. You can the night before you can set the ease-off. It should probably kick in at 5 o'clock, 2 hours before you want to exercise. That's a nice feature of the system. Or even with toddlers, if they or school children, if they have the PE lesson in the afternoon. Or at lunchtime, so you could even put it in, because children would usually forget to use the ease-off feature in advance. And then you just confirm, and then you see on the screen the blue, in blue, that the ease-off mode is scheduled or is actually turned on. Okay, some general advice. This is advice for all AID systems. You should avoid pre-exercise carb loading, because then the glucose goes up and the algorithm is trying hard to bring glucose levels down, and then you have the effect that you have more insulin on board than you should have, and that's prone to hypoglycemia. And then it's often better to drizzle in carbs as required as you go along, as you exercise, small amount of carbs. And you could reduce your bolus before exercise roughly by 50% or to start with. And even after exercise, you may need smaller boluses if you're just eating shortly after exercise. This is just some general advice. And you can also suspend insulin. Of course, that's what a lot of people do. This might be required for a longer duration of cardiovascular exercise. And sometimes you could even switch to the manual mode. So if it's not working with your closed loop system, okay, then just turn off the auto mode, go back to the manual mode, use temporary basal rates or suspend insulin delivery as you would have done prior to using the CamAPS or any AID system. So it's really very individual. So now I have some cases. So I found, because we are doing these diabetes camps, and the camp setting is usually different. The children are more active than during a standard day at school. So we had a very challenging day. There was an amusement park visit in the morning and afternoon swimming. So the initial approach was actually for this 11-year-old using the CamAPS system. What would you usually do at home? Because she was using it for a long time already. She has been part of the kids' AP studies, which were shown, these results were shown earlier today. Anyway, and she would usually actually reduce the bolus prior to exercise or the physical activity, and that's what she did actually. She only put in 18 grams of carbs and had more carbs, and then actually the system was actually working a bit harder to bring the glucose down, and then she was starting to get active, and she was on the lower side here. Okay, so that didn't really work well. Then we decided actually to put on the ease off feature, and we put it on for a longer duration, not just half an hour, which usually doesn't make any sense. But anyway, and then actually it was working quite nicely, quite stable glucose control, up until the moment when she stopped insulin delivery because she was actually swimming in the afternoon. And then not only for 1 hour or half an hour, but for 3 hours. So that then she ended up having high readings, and then the system was actually turned on. There was no correction bolus given, and the system actually kicked in and brought her glucose down very nicely. And although the management of exercise was not perfect, or of physical activity, she managed to have quite a decent day with 77% in range and 1% in hypoglycemia. So it was just a nice day where you could see several features or several approaches you could have with exercise or physical activity, and they might work or might not work so well, but overall she managed pretty well, although there are still things that could be improved in this setting. And then there's another example. So this is a guy who's active, who's planning to do a 50K run in the morning. So he actually did use the ESO feature quite early. He started it around here, at around 4 o'clock. He wanted to exercise at 8:30, so almost 4 hours in advance, because he had experienced hypoglycemia beforehand if he wouldn't turn on the feature in advance. And that's the beauty of the system. You could set it. And then he had, prior to starting the exercise, he had some extra carbs, because he thought starting at 180 or 200 might not be. He wanted to be a bit higher. And then he actually put even, he wasn't happy with the ease off, so he put in personal target glucose even higher than the ease off with 190 milligrams. And then he was exercising here. And then he actually had 25 grams of carbs. When blood sugar levels were down, although they were still in a decent range. And then he actually also had breakfast after the run, and the postprandial peak. There was a combination, well, it was quite high actually, combination of reduced bolus. There was hardly any insulin delivered over the last couple of hours, and he even forgot to turn off his personal target, so the closed loop was not kicking in that aggressively to help with the postprandial peak. So lessons learned. But this is what we see in daily life. There are different approaches to exercise using AID systems, and it's very individual actually. Yeah. Any comments or questions from your side?
I was just wondering whether there is, maybe it's a question for Roman, whether there is any data if there is a better, equal, or worse outcome if patients use more or less ease off and boost. Because my opinion is that whenever you use that, sport is a different story, but in everyday life, if it doesn't make much difference if you use it or not, because the system is already ahead of it. And have you ever looked at that? If you use how many time, whatever time, with these additional features, if there is any different outcome?
I think they want to hear from you, Roman.
We actually do analysis of boost data. We wanted to make it sure, so it's safe, because we're giving more insulin. And we found that if you use boost, your glucose is high, so you were thinking boost is not working. And the reason why it's like this, because people put boost when glucose is already high. So that's the reason why it is like this. So we demonstrated it's safe. It's giving more insulin in principle. So it is a feature which allows you to accommodate more insulin and safely. I think ethically it would be difficult to do studies, randomized clinical trials with or without boost. So we really have just observational data, and we believe it is a safe feature, and it's a unique feature which people use when they are running high post-meal, or when they have a mild illness and they need more insulin. So.
Yes, another question.
Last question,
Thanks,
because we're
Roman.
already
It's
running
not-
late.
Sorry. My Vatalva from France. It's not a problem if people use a lot boost and easier for the algorithm?
It is. So we would advise not to switch ease off and boost every half an hour. So one would need to use it reasonably. And we've seen people, and I think Julia also can comment on that. There are families who are used to tinker and who are used always to be in control. And this is one of the things they can do. So they feel obliged to do something for their children. So we would advise not to do so. Yeah.
You can end up in like a seesaw situation, which you want to avoid. And also the algorithm, the learning is, it doesn't learn when ease off and boost are on or not very well. So we would generally advise not to use it all the time. It should really be for sort of unusual circumstances. So either if your glucose is unusually high or if you're going to do something like exercise. It's not really for all the time use. And clinically, I always try, when people first start on closed loop, I always say, for the first 2 weeks, try and sit on your hands. Don't use them at all. Let the system learn first before you start tinkering. But yeah, some families are better at that than others. So I think, unfortunately, we've run out of time. Thank you so much for joining us today. It's been really great to have you. And thank you to Martin as well, and of course all our teams. If you have any other questions for us, we'll be around, so do feel free just to come up and approach us.